In this module, we're going to look at some examples of the upper and lower limb SEPs. A quick reminder of the electrode placement in the median nerve SEP. So we stimulate at the wrist, and the first recording electrode is ipsilateral at Erb's point. The second recording electrode is over cervical spine, and the third recording electrodes are over cortex. And so the tracings that we see follow the same order. So the tracing on the bottom will be the peripheral recording at Erb's point. The middle tracing is a cervical recording over cervical spine, and the top tracing is the cortical recording. This is an SEP recording from a 16-year-old girl presenting with query demyelinating condition. So we start with the bottom, where we see that the arm length of this girl is 63 centimeters, and we see that the technologist has noted for us that this child is cooperative. And so looking at the tracings, they look fairly clean, as one would expect from a cooperative child. Turning to the tracings, the left panel is from the left median nerve recording, and the right panel is the right median nerve recording. And so starting at the bottom, most tracings, these are the peripheral Erb's point recordings, and the arrow denotes the N9, the brachial plexus response, for both the left median nerve and the right median nerve. And then when we look at the bottom, we'll see that the technologist has written in the latency values, which are 9.1 for both the left and right arms, and the upper limits of normal is 12. So the Erb's point recordings are within normal limits for both arms at this point. Looking now at the middle tracing, which are the cervical spine recordings, we see a little N12 and a little N13. It's that W morphology that we're looking for. And then looking down at the table of numbers, the technologist has let us know that the right median nerve N12 is 10.7 and the N13 is 12.2. And the left median nerve is 10.8 and 12.2 for the N12 and N13 respectively. And so all of these are within normal limits. And finally, we'll look at the cortical recording, which is a top tracing. So for the left median nerve in the left panel, we see a little N20 and a nice prominent P22. And so in this case, where the waveform has a little plateau, we take the front of the plateau, or we could choose to triangulate, but in either case, it would still be within the upper limits of normal. Now looking to the right panel, for the N20, we'll see that there's a little negativity just before the prominent one. So there's actually an N18, N20 in this recording, but only the N20 values are noted by the technologist in the table below. And then there's a P22, which is quite clear and prominent, and so that number has been noted for us as well. After looking at the tracings and the absolute latencies of the different peaks, we then look at our table and look at the interpeak latencies. And the interpeak latencies are very important for telling us about central conduction. And so the first interpeak latency value we look at is the difference between the N13, which is cervical spine, and the N20, which is the first cortical response. And so you'll see that those values are circled in red on the table. And when we subtract the N13 from the N20, we get the interpeak latency, which is the green circle. And so, for example, for the right median nerve, the N20 is 18.5, the N13 is 12.2, the difference is 6.3. And this 6.3 tells us how long it takes to travel from the generator of the N13 at the cervical spine to the first cortical response. So it's the travel time up the spine through thalamal cortical tracts to the cortex. And then the second interpeak latency value that we're interested in is the value between the N20 and the P22. And so you'll see that the N20 value is subtracted from the N22, giving us the travel time between the first cortical generator of the N20 and then the generator of the P22. And so that tells us about intracortical conduction, the travel time within the cortex. Taken all together, this study would be interpreted as within normal limits bilaterally. And so all of the absolute values for all of our important peaks are within normal limits. and the interpeak latencies are within normal limits. And so for this patient with Cleary demyelinating condition, we can comment that both median nerve recordings are within normal limits. This is an SEP recording from a 6-year-old boy with a motor delay. Before we look at the tracings, we start with the table. And so we notice that the tech has marked for us that the child moves between being awake, crying and moving, and cooperative. And so this explains the quality of the tracing that we see, that there's a bit of noise in the cervical and peripheral recordings. And so this may be due to the child crying and moving and being awake. Although the cortical responses, which are a little more robust to movements, is quite clean and reproducible. Continuing with the table, we check on the left side that this is a table for a 6 to 9-year-old with a maximum arm length of 54 centimeters. And so we know this is a 6-year-old boy whose arm length is 51 centimeters. And so this is the appropriate table to use for this child. And then the last thing that we check is whether motor threshold was attained. And so we'll see the letters MT with the little check mark beside them, and that's the tech telling us that motor threshold or a thumb twitch was obtained for both arms in this child. On the left, we see a very nice, clear downward going response, and that's the N9 on the left median nerve. On the right, the N9 is not as well formed. But this may not be of concern, as we were told that the child was moving and crying, and so this may simply be due to the condition of the child. Looking down at the table, we can see the numbers, and the N9 latencies are prolonged on the right, but normal on the left. Looking now at the middle tracings, which are the recordings obtained from the cervical electrodes, we kind of see a little W that represents the N12, N13, and they're not well formed, possibly due to the patient moving and crying, possibly due to the child being tense. And so making our best attempt, we do mark an N12 and N13, and the technologist has written those numbers down below, and we see that they are prolonged. Looking now at the top tracings, which are the cortical recordings, so the left and right arm, the arrows point to the N20 and a very well-formed and clear P22. Looking down at the numbers, we'll see that the N20 and P22 values are also prolonged. It should be noted that while we can comment on the absolute latency delays that we see in the N20 and P22, they are no longer of clinical significance to us because we know that there's an N9 delay and that there are N12 and N13 delays. So these earlier delays may be what contribute to the delays that we see in the N20 and P22, and so we can't interpret them. So once we see an earlier delay, we cannot interpret later delays. And what we need to use at that point are interpeak latencies. After looking at the absolute latencies, we then turn to look at the interpeak latencies. And the interpeak latencies are still useful for us because regardless of whether there's an earlier delay, the interpeak latency still reflects the conduction between just the 2 points. And so when we look at the interpeak latencies, we note that there's a delay, a prolongation of the interpeak latency between the N13 and the N20 on the right median nerve. And so this suggests that there's a delay in the conduction between the generator of the N13, which is cervical spine, and the generator of the N20, which is the cortex. And so this interpeak latency delay suggests that there's a dysfunction along between cervical spine to cortex. So taking all of this together, this child has several abnormalities that contribute to an abnormal SEP report. The first abnormality is that there's a peripheral delay on the right median nerve, as we see in the delayed N9, and they also have a central conduction delay, as seen in the increased interpeak latency between the N13 to N20 on the right median nerve, suggesting a central conduction delay. As well, on the left median nerve, They have a delay in the N12, N13, so this suggests a nerve root dysfunction. And although their interpeak latency for the left stimulation is not prolonged, it may be early in the disease progression, and probably as the disease progresses, we would see this delay coming up. So there's a right median nerve delay peripherally and centrally, and on the left median nerve, there's a nerve root delay, a nerve root dysfunction. I just want to show one more example. This is a 6-year-old girl with a known polyradiculopathy. And so this is a recording from her right median nerve, and it's beautiful. The tracings are clean and reproducible. The waveforms are very well delineated and easy to identify. And so starting at the bottom, we see a clear Erb's point. That little negative going peak is the N9. And then in the middle tracing, we see a nice N12, N13, that little W. Those are well seen. And then the cortical response is also very nice. And the technologist has marked on it all of the little peaks that we can see, starting with a P14, and then a P16, and then a little N18, N20, and then the big prominent P22. So what should be noted is when we look at the table, the N12, N13 numbers are delayed for her age and arm length. And so this is consistent with a known nerve root dysfunction, a known radiculopathy. We will now look at the median nerve SEP in neonates. Just a reminder that in the babies, the clinical question of interest is usually regarding cortical function. And so for this reason, we only place electrodes on the scalp to record the responses from the cortex. And so when we look at the tracings, there are no peripheral or cervical tracings. All of the tracings that we see are from the cortex, but acquired at different band passes. This is a recording from a 7-day-old term infant. And so at term, the peaks that we expect to see are the P16, N20, and P22. And so the panel on the left is the left SEP, and the panel on the right is the right SEP. And we'll see that there is a maybe questionable P16 marked by the first arrow. The little negative going portion is the N20, and then the big positivity is the P22. The 4 tracings in each of these panels are recordings at 4 different bandwidths. The top tracing is the bandwidth that's used within the guidelines. The other bandwidths are narrower and cut out a lot of the noise. And so you can see that the tracings look more and more smooth. But when we cut out the noise using these kinds of filters, it changes the latencies of the responses. And so it's nice if you're using the 4th tracing to identify the peaks, it's nice to try to track up to the first tracing to see if you can find the same peak and to use the latency from the first tracing, as that is more accurate. So in this recording, we'll see that the technologist has given us the latencies for the P16, N20, and P22 for both arms, and they are below the upper limits of normal. And so this is a normal bilateral recording. This is another recording of an SEP in a 7-day-old term baby with HIE, just to show you how different they can look. And so this one, the peaks are actually very well formed. And so the most prominent positivity is the P22, and then the negativity seen just before the positivity is identified as the N20. And so this is a normal study bilaterally. We now move to the posterior tibial nerve SEP in children. And so just a reminder of the recording electrodes. We stimulate at the ankle. The first recording electrode is a peripheral response recorded over popliteal fossa. The second recording electrode is over lumbar spine. And then the third recording electrodes are over the cortex at vertex. And so the tracings that we see follow the same order, with the bottommost tracing being the popliteal response, and the topmost tracing being the cortical response. What's different is that the middle 3 tracings in our recordings are different montages using the lumbar spine electrodes. And so they may be L1 reference to iliac crest, L5 reference to iliac crest, or L1 reference to L5. And using these different montages allows us to better see and identify the lumbar response. These are lower limb SEPs from a 13-year-old girl with a leg length of 90 centimeters. And so we'll see the left posterior tibial nerve recording on the left-hand side and the right PTN on the right-hand side. The first things that we look at are that we have the appropriate table, and so we know this is a 13-year-old with a leg length of 90, and so in this table it's the lower row of upper limits of normal that are appropriate for a 14 to 17-year-old with a maximum leg length of 96 centimeters. The second thing we look for is the state of the patient, and although it's not marked, we can assume that this patient is fairly cooperative because the recordings are fairly quiet and well reproduced. And then the third thing we look for is whether motor threshold was attained, and we see by the check marks in the last column of the table that motor threshold was attained for both legs. So we start with the bottommost tracing, which is a recording from the electrode placed at popliteal fossa, and so it's a peripheral response, and we see a very nice, clear, negative going response that's under 10 milliseconds, and so this would be the popliteal response. We're going to jump up to the top tracing, which is the cortical response, as it is a little easier to identify the cortical responses than it is to identify the lumbar responses, so we'll save the lumbar responses for last. A typical cortical response looks like a big M. So there's an N30 negative going, then a positive P35, an N45, P55, making kind of an M shape. Although there's a lot of individual variation on the second peak, the N45, P55, and so it may or may not be very big or clear, which is fine. So as long as the N30 and P35 can be identified, those are the mandatory components. And so we see here for both the left and right legs, there's a nice N30, P35. The N45, P55 is a little bit smaller, a little less well formed. But when we look at the latencies, they're all below the upper limits of normal. And so these cortical responses look normal. The lumbar responses are a little difficult to identify here, as they often are, because they're quite small and the recordings can be quite noisy. But what we're looking for is a little phase reversal in around 20 milliseconds, which would be the P21. And so in this case, the arrows would mark what might be a phase reversal and possibly a P21 for both the right and left legs. And when we look at the latencies, they correspond to the upper limits of normal, and they're within the upper limits of normal. And so with a little caution, we might call these the P21. And why it's helpful to try to identify a P21 is that having a P21 latency gives us an interpeak latency between the P21 and P35, which is the lumbar response traveling to the cortex. And so that gives us a measure of central conduction through the spine, brainstem to the cortex. And so it's very helpful to try and find the P21 and the P35. And so you'll see at the bottom, the circles in red are the P21 and P35 latencies, and then there's a calculation in blue that shows the interpeak latency between the P21 and P35, which is a measure of central conduction time. So in conclusion, this study is a normal bilateral posterior tibial nerve study with normal popliteal responses, normal cortical responses, and normal central conduction between the lumbar spine and the cortex. I would like to show you one abnormal PTN SEP recording. This is from a 13-year-old girl with a leg length of 80 centimeters. The left panel is her left PTN and the right panel is her right PTN. And you'll notice right off that very reproducibly there is no cortical response in the top tracing for either leg. Now when we look down and look at the popliteal response, there is also no clear popliteal response for either leg. And so this study is abnormal, but not abnormal due to absent cortical function. We cannot comment on the cortical responses because we do not get a good peripheral response. And so this study is abnormal due to absent peripheral responses bilaterally, with the possibility that this child has some sort of peripheral disease that is preventing the signal from traveling from her ankle into her lumbar spine. What is really helpful for localizing dysfunction is to record both upper and lower limb SEPs and to look at the pattern of abnormalities that show up. And by looking at this pattern of abnormalities, we can start to localize where the dysfunction may be. And so I will demonstrate that in this next case. This is a 9-year-old boy with an arm length of 55 centimeters. These are the upper limb median nerve recordings. And so first off, the recordings look fairly clean. They're reproducible. And starting at the bottom tracing, we see an N9, we see the little N12, N13 in the cervical recording. And then, although it overlaps a little bit, we see a very clear N20, P22. And when we look at the numbers, we check first that we have an appropriate age and arm length table, which it is. And then we check that motor threshold was attained, which it was, as we can see in the bottom right. There, the MT lines are checked off. And then we just scan the numbers, and we see that all of the numbers are below the upper limits of normal for all the absolute latencies as well as the interpeak latencies. And so therefore, this is a normal upper limb SEP study bilaterally. These are the posterior tibial nerve recordings in the same boy. And so his leg length is 77 centimeters. And so checking the table, we have an appropriate table with the right age and leg length. And then we can also check that motor threshold was attained for both right and left leg. Now, when we look at the tracings, they're clear and they're reproducible. However, the cortical responses are absent. It's not certain that there are lumbar responses, but the popliteal, the peripheral responses are clear. And so there's a clear popliteal response, and this is noted in the table as well, possible lumbar responses, and absent cortical responses. Taking these two studies together, we can localize the dysfunction for this child. So the upper limb SEPs were entirely normal, suggesting that the peripheral conduction as well as central conduction from cervical spine on up to the cortex is normal. The lower limb SEPs show that peripheral conduction through the leg is normal. However, we're not sure if the signal enters normally into the lumbar spine or whether it travels normally up lumbar spine towards cervical spine. And so taking these two studies together, we can localize the abnormality between cervical and lumbar spine, and also possibly a dysfunction at the lumbar nerve root. And so we can't dissociate those two things, but it's an abnormal study, either due to a nerve root dysfunction at lumbar spine or a central conduction problem between lumbar spine to cervical spine. I'd like to show you a second combination study, this time in a 6-year-old boy. This is an upper limb SEP recording in a 6-year-old boy with an arm length of 45 centimeters. Looking at the tracings, they're very nice and clean and reproducible. Going down to the numbers, we check first that the age and arm length are appropriate for this child. And then scanning across the numbers, we see that there are increases for the N20 and P22 in the absolute latencies, and then there are prolongations in the interpeak latencies for the N13 to N20 and the N20 to P22. So the interpretation of this study is that it's an abnormal study due to bilateral interpeak latency delays of the N13 to N20 and the N20 to P22, which are interpreted as central conduction delays in cervical spine to cortex, represented by the N13 to N20 numbers, and then an intracortical delay or a cortical dysfunction as indicated by the N20 to P22 numbers. This is the posterior tibial nerve recording in the same 6-year-old boy. Looking at the tracings, again, they're clean and reproducible. And I'd like to point at the lumbar responses on the left leg. They're really beautiful. And so it's very clear to see the phase reversal where the positive going peak In the middle tracing is the P21, and it phase reverses with the next tracing below it. And we also see a fairly clear peripheral response in the record. The lumbar response in the right leg PTN is not as well formed, but possibly it's present, and so the technologist has marked a N18P21 for us on that tracing. However, the cortical responses for either of the leg stimulations is not well seen. And so this study on its own is abnormal due to absent cortical responses, and so that would localize the dysfunction to be somewhere after entry into the nerve root, because we see lumbar responses, which indicates that's fairly normal entry into lumbar spine, but above that, we do not see any cortical responses, and so that would suggest abnormal central conduction above lumbar spine. Now, putting the two studies together. For the upper limb SEP, we have an abnormal study bilaterally due to a central conduction delay that occurs from cervical spine on up to the cortex. And then for the posterior tibial nerve SEPs, we also see an abnormal study where it's abnormal from the lumbar spine on up. And so taken together, this would suggest that this child has a dysfunction within the spinal column from lumbar spine all the way up to the cortex.